Catholic University, Nursery Career, Valencia Aro Kerli. Vedolizumab versus Adalimumab for moderate to severe ulcerative colitis. Definition: Ulcerative colitis is a chronic inflammatory condition of a large intestine that is limited to the mucosal layer of the colon. It almost always involves the rectum, and may extend in a proximal and continuous fashion to involve other portions of the colon. The pattern of disease activity is characterized by periods of active inflammation alternate with periods of remission.
What is ulcerative colitis? Ulcerative colitis is a chronic condition characterized by inflammation and sores or ulcers in the rectum and colon or large intestine. Ulcerative colitis can be distinguished based on how much of the large intestine is involved. When ulcerative colitis involves only the rectum, it is referred to as proctitis. If the left side of the colon is involved, it is known as left-sided colitis. When the entire colon is involved, it is known as pancolitis. Ulcerative colitis is characterized by periods of time with active inflammation when the patient is experiencing symptoms, and periods of time when the inflammation is turned off and the patient feels well. We call these periods of wellness remission. Many patients with ulcerative colitis have long periods of remission, alternating with periods of active inflammation, which are called flares. Some patients with ulcerative colitis have more severe flares than others. Although the cause of ulcerative colitis is not known, many factors can contribute to a person's risk of having ulcerative colitis, but most can be thought of in three categories: genetic predisposition, environmental factors, and a dysregulated immune response in the GI tract, which causes the inflammation. Environmental factors may include infections, smoking, and taking antibiotics or nonsteroidal anti-inflammatory drugs, or NSAIDs. In ulcerative colitis, inflammation appears within the colon, and the immune system works to combat the bacteria and viruses as it does with a cut on the surface of the skin. However, the difference is that the immune system is not able to turn itself off after it rids the body of the bacteria or viruses, so the ulcers remain until they are treated with medicine or surgery. This chronic inflammation is what causes the symptoms of ulcerative colitis. In ulcerative colitis, the rectum, the last 6 inches of the large intestine, is always involved. The inflammation may involve additional areas of the large intestine above this area. In some patients, the inflammation may extend further up into the colon, and it is thought that in some patients the inflammation extends higher up over time. Approximately half of patients who do not have the whole colon involved at the time of diagnosis eventually progress to more extensive disease, which may result in new symptoms or loss of response to an existing therapy. Most of the symptoms of ulcerative colitis are related to the inflammation of the rectum. When the rectum is inflamed, it is not able to store contents or distinguish gas from liquid. Because of this, patients frequently feel the urge to run to the bathroom or fear that they will leak or have an accident. Other symptoms of ulcerative colitis can include frequent small stools, fatigue, low energy, and rarely fever. Because the rectum is always involved in ulcerative colitis, patients usually experience similar symptoms regardless of how much of the colon is involved. In addition to symptoms involving the colon, ulcerative colitis can affect other parts of the body. Symptoms outside of the GI tract can include joint pain, liver inflammation, osteoporosis, skin problems, eye problems, mouth ulcers, and anemia. Patients with ulcerative colitis should expect to lead normal lives. An important goal of the healthcare provider is to help people manage the disease, rather than having the disease manage them.
Application in nursing. Most patients with UC are treated with pharmacologic therapy, and multiple drugs are available. Therapies can be grouped as induction therapies, appropriate for longer use. Some therapy biologic agents are used for both induction and maintenance of remission.
Chronic inflammation in IBD and how anti-TNF therapy works. The immune system is composed of a network of cells that work together to defend the body against infections and disease. Cells in the immune system can cause inflammation to eliminate an infection in the body. Once the infection has been cleared, the immune defenses begin to wind down and switch off until the next infection signals them to switch back on. One theory is that the immune system does not respond to the body's off switch in people with inflammatory bowel disease, IBD, leading to an overactive immune system and chronic inflammation in the gut. This chronic inflammation is spurred on by a large imbalance of chemicals called cytokines, which act as on signals to cause inflammation. Another theory of IBD is that the immune system is constantly being stimulated and therefore is always in an activated state, although the cause is not known. One of the major signals of inflammation is a cytokine known as tumor necrosis factor alpha, or TNF-alpha, which is produced by some cells of the immune system. When TNF-alpha is released from cells, it interacts with IBD. Controlling inflammation is critical to maintaining good health, improving quality of life, and reducing the chance of needing surgery. One way to reduce inflammation is by modifying or suppressing the immune system through medications. Medications that modify the normal response of the immune system are called immunomodulators, and those that specifically target and suppress the effects of TNF-alpha are known as anti-TNF agents. Anti-TNF agents are part of a class of medications known as biologic therapies. Modifying or suppressing the immune system can restore balance in the system and therefore prevent ongoing damage. Reducing the amount of TNF-alpha that is circulating in the blood is associated with the reduction of inflammation in IBD and improvement in the disease symptoms. Anti-TNF medications work by attaching to free-floating TNF-alpha outside of cells, as well as transmembrane TNF-alpha found on the cell surface. Because it is attached to the anti-TNF medication, TNF-alpha is unable to interact with its receptors on the surface of cells in the gut to cause inflammation. Examples of anti-TNF medications used in IBD include infliximab, adalimumab, and certolizumab pegol. These drugs have each shown to be effective in reducing signs and symptoms of inflammation in Crohn's disease and ulcerative colitis. In fact, inflammation and ulcers can be healed within a few weeks in some patients taking anti-TNF therapy. By binding to TNF-alpha, these medications can reduce inflammation in the gut caused by TNF-alpha. Some patients greatly benefit from anti-TNF therapy. Regular treatment with some anti-TNF agents may reduce the number of hospitalizations by half and decrease the number of surgeries in patients with Crohn's disease and ulcerative colitis. However, as with any medication, it is important to understand the side effects. The most common risk of anti-TNF therapy is losing response to the drug, which can happen in as many as 50% of patients after 1 year of treatment. There are a variety of ways to prevent loss of response, but one of the most important is staying on a regular schedule of infusions. In this animation, we have reviewed how anti-TNF therapy works. However, there are many other therapies in development that target additional molecules involved in inflammation.
In patients with ulcerative colitis of moderate severe activity, vedolizumab was superior to adalimumab with respect to the achievement of clinical remission and endoscopic improvement, but not to corticosteroid-free clinical remission. Cons. Available treatment includes several kinds of medication, depending on the severity of the disease. Patients treated with vedolizumab have a lower percentage of adverse events and serious adverse events than those treated with adalimumab. Vedolizumab implies a theoretical risk of favoring the development of serious brain infection.
Let's learn about the role of white blood cells and inflammation in moderate to severe ulcerative colitis and Crohn's disease. White blood cells are programmed to travel to different parts of the body as part of the normal immune response to protect your body from diseases. Certain white blood cells, like the ones represented here, are directed to the gastrointestinal tract. For the purpose of simplification, let's focus on just one blood vessel passing through the GI tract. In people with ulcerative colitis and Crohn's disease, there's an increased number of white blood cells entering the GI tract. The increased number of white blood cells causes inflammation in the GI tract. This inflammation can lead to the symptoms most commonly seen in people who have ulcerative colitis or Crohn's disease. We'll show you what happens when Entyvio, represented in purple here, is added to the equation. Entyvio, vedolizumab, is a prescription medicine used in adults with moderate to severe ulcerative colitis or Crohn's disease when certain other medicines have not worked well enough or cannot be tolerated. But how exactly does Entyvio work? Entyvio works by focusing right in the GI tract to help control damaging inflammation. Entyvio binds to a protein on the GI-directed white blood cells, keeping them from entering the GI tract. Now, GI-directed white blood cells continue moving through the bloodstream. With fewer white blood cells in the GI tract, Entyvio helps reduce inflammation and symptoms of ulcerative colitis or Crohn's disease. Ask your doctor about Entyvio, relief and remission within reach.
Important to have an allergic reaction. Tell your healthcare provider or get immediate medical help if you get any of these symptoms during or after an infusion of Entyvio. Rash, itching, swelling of your lips, tongue, throat, or face, shortness of breath or trouble breathing, wheezing, dizziness, feeling hot, or palpitations, feel like your heart is racing. Entyvio may increase your risk of getting a serious infection. Before receiving and during treatment with Entyvio, tell your healthcare provider if you think you have an infection or symptoms of an infection, such as fever, chills, muscle aches, cough, shortness of breath, runny nose, sore throat, red or painful skin or sores on your body, tiredness, or pain during urination. Although it has not been reported with Entyvio, it may be possible for a person to get progressive multifocal leukoencephalopathy, PML, a rare serious brain infection caused by a virus. People with weakened immune systems can get PML, which can result in death or severe disability. There is no known treatment, prevention, or cure for PML. Tell your healthcare provider right away if you have any of the following symptoms: confusion or problems thinking, loss of balance, change in the way you walk or talk, decreased strength or weakness on one side of the body, blurred vision, or loss of vision. Liver problems can happen in people who receive Entyvio. Tell your healthcare provider right away if you have any of the following symptoms: tiredness, loss of appetite, pain on the right side of your abdomen, dark urine, or yellowing of the skin and eyes, jaundice. The most common side effects of Entyvio include common cold, headache, joint pain, nausea, fever, infections of the nose and throat, tiredness, cough, bronchitis, flu, back pain, rash, itching, sinus infection, throat pain, and pain in extremities. These are not all the possible side effects of Entyvio. Call your healthcare provider for medical advice about side effects. Before receiving Entyvio, tell your healthcare provider about all of your medical conditions, including if you have or think you may have an infection or have infections that keep coming back, have liver problems, have tuberculosis, TB, or have been in close contact with someone with TB,
have recently received or are scheduled to receive a vaccine, or if you are pregnant, breastfeeding, plan to become pregnant, or plan to breastfeed. Please see accompanying full prescribing information, including the medication guide for Entyvio, and talk with your healthcare provider. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Uses of Entyvio, vedolizumab. Entyvio is a prescription medication used in adults with moderate to severe ulcerative colitis, UC, when certain other UC medicines have not worked well enough or cannot be tolerated. Entyvio may help to begin reducing some symptoms, induce and maintain remission, reduce or stop the use of corticosteroids, and improve the way the lining of your large intestine looks to your healthcare provider. With moderate to severe Crohn's disease, CD, when certain other CD medicines have not worked well enough or cannot be tolerated, Entyvio may help to begin reducing some symptoms, achieve remission, and reduce or stop the use of corticosteroids.
Let's learn.
Issues applied in Ecuador. It is particularly serious complication in almost 10% of people affected by ulcerative colitis. The first outbreak progressed very rapidly, becoming very serious with massive hemorrhage after 20 years of illness. Approximately 7 to 10% of affected people develop cancer.
We present this paper to introduce vedolizumab in the treatment of moderate to severe ulcerative colitis. This paper highlights the preclinical development of vedolizumab and details the landmark studies that have led to its approval in the United States. Vedolizumab is manufactured by Takeda Pharmaceuticals and received FDA approval in May of 2014. It is a humanized monoclonal antibody which is gut-selective. Its action is to bind to alpha-4 beta-7 molecules, subsequently inhibiting the infiltration of T lymphocytes into inflamed gastrointestinal tissue. The safety and efficacy of vedolizumab in the induction and maintenance of ulcerative colitis was established in the Gemini 1 study. The study was a randomized, double-blinded, placebo-controlled trial which met primary endpoints of clinical remission and clinical response at weeks 6 and weeks 52. More so, patients in the treatment group with vedolizumab showed more mucosal healing than patients in the placebo group. The added benefit of treatment with vedolizumab is that it is a very well-tolerated medication. Side effects reported were similar to the placebo group. The most common reported symptoms were fatigue and nasopharyngitis. However, there is a theoretical concern of PML, which is a progressive fatal brain infection that has been associated with its parent molecule adalimumab. However, to date, no reported cases of PML have been associated with treatment of vedolizumab. In conclusion, we feel vedolizumab shows favorable promise in the treatment of moderate to severe ulcerative colitis. As we gain more experience, the inevitable question is its placement in the treatment algorithm of ulcerative colitis. Will it remain a second-line agent once anti-TNF agents have failed, or can it be considered as a first-line therapy in certain circumstances?
Conclusion: vedolizumab is the best option as the first biologic agent in UC due to its high efficacy and safety profile. However, keep in mind that it has relative short onset of action and that it is often necessary to combine the use of steroids until vedolizumab takes effect.
Ulcerative colitis is one of the most common forms of inflammatory bowel disease. and is characterized by inflammation of the colon and the rectum. The walls of the colon, also known as the mucosa, become inflamed and no longer provide an effective barrier between the inner cavity and the surrounding connective tissue, allowing gut microbes to cross the epithelial layer. This causes inflammation of the mucosa and leads to a raft of unpleasant symptoms such as abdominal pain, diarrhea, fatigue, and rectal bleeding. There are several commonly used anti-inflammatory and immunosuppressive drugs, but they come with side effects and aren't long-lasting for many patients. Currently, 15% of people with ulcerative colitis will require surgery to remove some or all of the colon within 20 years of diagnosis. Luckily, new insights into the immunology of this condition are helping scientists develop new, effective treatments. One new class of treatments is aimed at preventing the inflammation in the first place by bolstering the physical integrity of the colon's epithelium. This keeps the immune-triggering bugs confined to the interior of the colon. Some of these treatments work by exploiting a human protein called IL-22, which helps strengthen the epithelial layer. One new drug in development targets the receptor for IL-22 on the epithelium itself, activating it and thereby initiating healing of epithelial cells and the mucous layer. This drug is currently in phase 2 trials. Researchers are also trying to use a plant product called Indigo naturalis, which encourages immune cells in the area to release IL-22, again healing the epithelial barrier. There are also new therapies emerging that prevent immune cells from entering the affected area, where they might become activated to invoke an inflammatory response. One way to do this is to inhibit proteins called integrins which live on the surface of T cells. A new antibody drug that works this way stops T cells from getting across the blood vessel wall into the mucosa and also blocks their binding to the epithelium. This drug appears to effectively reduce pain and inflammation. Another group of drugs uses a totally different approach, targeting key inflammatory signals between different immune cells. For example, one new drug tampers with the cellular machinery inside T cells so that they no longer respond to messages from macrophages. In a pivotal phase 3 trial, this drug induced remission in over 40% of patients and has now been approved for the treatment of active ulcerative colitis. A final approach to treating this disease is to restore the healthy balance of the gut microbiome. One way of doing this is to use probiotic bacteria strains. Adding these commensal bacteria back into the intestine's gut community has been shown to quell inflammation and restore normal intestinal function. One particular probiotic, known as E. coli Nisle, has been shown to keep symptoms at bay, just as effectively as widely used anti-inflammatory drugs. Fecal transplantation from healthy donors is also being experimented with, although results to date are conflicting. At least one recent study on multi-donor stool transplantation has shown promising results, however, eliminating symptoms in a quarter of patients. As new approaches to tackling this disease come onto the market, the hope is that more patients will be free of symptoms for longer and won't go on to need aggressive surgery.